Welcome to this BTOG podcast. My name is Emma O'Dowd and I'm a respiratory physician and I'm a BTOG steering committee member. And this is part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their fields and tackle the most important questions we all face in the diagnosis and treatment of thoracic cancers. It's important to say that the sponsors of BTOG do not have any role whatsoever in the planning, content, or delivery of anything discussed. And today's podcast is BTOG Does Lung Neuroendocrine Tumours, and it's a pleasure to introduce Professor Matt Evison and Professor Mansoor, who are both based in Manchester. Matt is a fellow BTOG steering committee member and has done several podcasts previously, and Was is a professor of medical oncology from the Christie and is the lead for the lung neuroendocrine service there. So welcome, both of you.
Thank you.
And what we're going to do is we're going to discuss several aspects to do with lung neuroendocrine tumours. And for those people who are looking at podcasts on a platform where you actually have vision as well as audio, we do have a slide deck that is available. So what I'm going to do is I'm just going to start sharing those slides now and we'll start having a chat through some of the topics. And actually, what you might notice, first of all, is that I've changed the title of the podcast, which we've actually just discussed. And that leads us on to probably the first section, which is what are lung neuroendocrine tumours? And Matt put the what name should we use? So Matt, I don't know if you want to kick off with why are we not calling them carcinoids anymore?
Yeah. So first, it's brilliant that we've got the opportunity to do a podcast on lung nets. A lot of this came from we ran a national event recently, an education event dedicated to lung nets. There was in Manchester. There was a great turnout for it. I think there's a real eagerness to understand more about this. So all members of the lung cancer MDT encounter patients with lung nets, and I think there's a need to understand these better. In fact, at the education day, our first topic and speaker was about what should every clinician know, because as I say, we encounter these patients, and I'm sure what will come out in some of our discussions today is if we don't have a good understanding and don't provide good information, it can affect experience of care, and we'll talk about some of the pitfalls in communication. So these are rare tumours of the diffuse neuroendocrine system, and these cells and this system touches the nervous system, it touches the endocrine system, it touches the immune system. So, and it helps to explain why these tumours can be secretory, they can be functional, and secrete hormones. And from a lung perspective, they make up about 1 to 2% of lung cancers. And when I say they, I mean well-differentiated lung neuroendocrine tumours. And so that is one part of a spectrum of lung neuroendocrine tumours. And at the opposite end is the poorly differentiated, the ones that we're very, very familiar with, large cell neuroendocrine tumours and small cell lung cancer. But at the opposite end of that is the well-differentiated tumours. And you mentioned in the introduction about carcinoids, and that's a name that's we've known for a long time. And actually, at the education day, we were taught that I think it was a German physician, and that name came from being carcinoma-like. And with some initial thoughts of it being a benign tumour, and of course they're not benign tumours, they are malignant tumours, and that's where the origin and almost genesis of that word is. But there's a much more familiar and there's a more specific grading system that particularly is applied to the GI nets, which is grade 1, grade 2. We've been taught typical carcinoid and atypical carcinoid, but
I was going to say I think we're all still using that, which suggests that we are behind the GI world in how we think about these tumours, I guess.
And I'm going to ask Waz what he thinks about this. What should our terms be? And grade 1 would be the typical carcinoids that are the vast majority of the well-differentiated lung nets. I think 9 out of 10 are grade 1, and grade 2 being what we have called atypical carcinoids. There can be a rare genetic component to them, so some are associated with MEN1, which is important to know. And I think why that we get the name right is so important is ready, I think, for what's coming in the future. And again, GI nets are ahead of us. They've categorized an extra category of grade 3, of where there is, a more aggressive disease and rightly getting its own group. And so for us to kind of align ourselves and prepare ourselves for that, because it does fit, I think Waz can tell us that the WHO may well, create a grade 1, 2, and 3 for lung neuroendocrine tumors as well. It feels like it's an important moment that we get the name and terminology right. So Waz, what do you think? What should we be calling these?
Yeah, no, thank you, Matt. That really kind of explains. So it was Obendorfer in the 18th century that called these things carcinoid, which is German for something that looks like a cancer. But of course, when he looked up from his microscope, he could see patients suffering from cancers. And we now know in 2026 that these are very much cancers. They have malignant potential. And in fact, they often express their malignant potential. And so they are most definitely cancers. And so over the years, as you've explained, the GI nets have been evolving their nomenclature, and the lung fraternity have kind of struggled with that. And it's time we probably do need to change. So as Matt has already explained, grade 3 neuroendocrine tumors or neuroendocrine cancers of the lung are the small cell cancers and the large cell cancers, and they are poorly differentiated cancers, and they are defined as grade 3. Then there is grade 2, which is the atypical neuroendocrine tumor, which traditionally was called the atypical neuroendocrine tumor. We now prefer to call it grade 2, well-differentiated neuroendocrine cancer. And then there is grade 1, which is the typical neuroendocrine tumor, which we used to call typical. We now prefer to call that grade 1. And so you get grade 1, grade 2, and then the 2 grade 3s. And in between the grade 3s and the grade 2, there is a new cancer that is being defined, which is well differentiated, but grade 3. And we are starting to call them the supracarcinoids. And it's because of this complexity that we felt that we need to move away from using typical, atypical, and the word carcinoid, because they are cancers, and because typical and atypical cause lots of typos and lots of problems in describing which cancer we're dealing with. And so that's why the changes are now coming in. And so as the GI net specialists have moved away from calling these carcinoids, we probably now need to move away from calling them carcinoids, atypical and typicals. And we need to refer to the well-differentiated nets as grade 1 or grade 2 nets.
And I think that brings us on to that importance of language and communication, which I think both of you have highlighted already. But actually, there are a lot of common pitfalls that I think people still call these non-cancerous, don't they? When people have had a surgical resection, they're told that they've essentially had a benign resection and everything's fine. So I wonder if we could touch on what we need to do in terms of language and communication.
Yeah, so perhaps I can start on this slide and then Matt can finish on it. So I see many patients post-resection and they come to me wondering why they're there because they've had a benign entity removed from their bodies, and so the job is done, right? And then they discover that they've got a 15-year follow-up, and I talk to them about a chance of relapse and a chance of this disease metastasizing, and suddenly it comes to fruition in their heads that what they're dealing with is not a benign entity. And of course, when they fill out insurance documents, if they're ticking off, did you have a cancer? and they tick off no because I was told it was a benign tumour, they run into problems with that. So for that reason, we need to really move away from calling these benign. They're not benign. We need to move away from really saying to people that these cancers are non-aggressive, because actually there's a spectrum within them that is very aggressive, even within the grade 1. So the typical neuroendocrine tumours, there is a spectrum within them that is very aggressive. And so we probably need to move away from using the word benign, because I can't believe that there's any specialists in Europe that believes that these are actually benign cancers. What they're actually probably implying is that they are non-aggressive. But even that is probably not quite right. Most of them might be non-aggressive, but the ones that are aggressive can be very aggressive. And so that nomenclature is important, and using the correct nomenclature builds on a patient's trust. By giving them the warning shots early about what this is, means that we don't have to build on that later on when things are not going right for the patient. And so trust in that comes from empowerment, and empowerment comes from how the experts tell the knowledge to the patient. And so I think that that's probably very important. And then, of course, patients often, so this speciality is plagued by second opinions. And second opinions, I think, is a surrogate for a patient seeking their own MDT approach. And so, although second opinions are encouraged and it's a good thing, where you get an outline specialty where you get lots of second opinions, so about 70% of my practice is second opinions, it's because the patients are not getting what they need from their first opinion. And so it's about using the right nomenclature in the right way and informing the patient in the right way to get to where we need to get to.
And I guess that sort of moves us nicely on to how do we deliver specialist lung neuroendocrine care, which seems to be much more established, again, from a GI perspective. And I know that's something that both of you have been discussing after the day a couple of weeks ago that we had.
Yeah, and in fact, it was one of his talks on the day that really highlighted something I think a lot of us hadn't quite appreciated, and that in the GI net pathway, it is GI specialists diagnosing and GI specialists taking over the management and treatment. For lung nets, it's lung cancer MDT and respiratory physicians, thoracic surgeons involved in that care, which then hands over to a special net specialists, which are often GI net specialists who care for patients with lung nets as well. And so there's that transfer of care that isn't there for our in all of our lung cancer MDT sit together across the spectrum of diagnosis and treatment. But for lung nets, there's that little bit of fragmentation. And I think even just the awareness of that just opens your eyes to it, makes it visible. And it really, I think, highlighted just how important it's been in Greater Manchester that we have created these links between Waz and his team and a specialist net team and the thoracic team, physicians and surgeons. We've worked really hard to try and bring those people together so that we know each other and that there's lines of communication between each other. We have a group in Greater Manchester that meets quarterly to discuss clinical pathways, to discuss research projects and what we can do to deliver better care across the region for patients with lung nets. But that for me was a real take-home message from the education day. Whilst I don't know what your experience is it from that side?
Yeah, no. So these types of cancers are extremely complex and they require an MDT approach. And that MDT approach, really, the platform for that is the net specialist who might be an oncologist, but might be a gastroenterologist, a NET specialist, the cardiothoracic team, and the respiratory team. I think without that trinity, it's very difficult to manage these cancers. And then beyond that, you might need the endocrinologists and lots of other people, but actually that is the basics of this. So understanding that if a GI specialist is looking after lung neuroendocrine tumors, that they do require the cardiothoracic and respiratory teams close by.
And I think certainly from my experience, this is not really a joined up pathway with this expertise in probably most centres. I think it's unusual, the Manchester experience, but it is something that we probably need to be discussing more as part of this education, and hopefully that will come out of the podcast. And I guess our pathways in lung are all set up for people essentially who don't necessarily have carcinoids. And I know that Matt, you presented something at the education day about whether we did need a slightly different optimal diagnostic pathway if people have a high suspicion of carcinoid.
Again, this I get for me was a really big take home from that day and a real call to action. Because you're right, from a respiratory physician perspective, we have been doing the lung cancer pathway for a long time. It's been drilled into us about how to do that. We're trying to make efficiency gains at every single bit. And it's very much a PET first approach before you undergo a biopsy. We do not do a staging EBUS without a PET scan. We don't biopsy a nodule without a PET scan and understanding its probability of malignancy. And for extrathoracic staging, that really is that first point of call. But actually preparing the talk for that education day, you realise the international guidance for well-differentiated lung nets is completely different. And it's tissue first, because that then informs your optimal way of extrathoracic staging. So it got us thinking about, to do this pathway, you do have to try and pick out those cases where you've got a really high suspicion of lung nets. And I think that's often quite possible. I think there was a time when lung nets were a post-operative diagnosis, and it came after surgery, but it's not the case anymore. We know from the 10-year data in GM, the last 10 years, we diagnose over 2/3 before pre-operatively. And so this is now a pre-operative diagnosis. And there are key CT findings. We all know these: round, well circumscribed, homogeneously enhancing. We know that they're vascular, that they take up contrast. That's normally very homogeneous. They can often be endobronchial. And really importantly is past imaging. Because actually, if you've got evidence of relatively slow growth with those imaging characteristics, you really start to think of a well-differentiated lung net. And so, we have to do the basics right. We have to make sure we do contrast-enhanced staging, not CTPAs, not low-dose CTs. That is our starting point, a contrast-enhanced imaging. And we're very, very familiar with surgical workup. That doesn't have to change, and we can lift and shift that from our practice currently. There is the endocrine side of things, and that it's being systematic and making sure that we look for symptoms and signs of carcinoid syndrome, of Cushing's, checking the relevant biochemistry and an endocrine profile. But for that's the specific pathway. Tissue first does feel like the right approach. And you would still do a staging EBUS of anyone that's got a intrathoracic lymph node of over 10 millimeters in short axis. Still do your brain imaging if it's clinical stage 2 or 3, as in the lung cancer pathway, up front. But tissue first, because if that does confirm a well-differentiated lung net, we know that somatostatin receptor PET imaging is more effective at staging than FDG PET. And so it changes our approach, and that those patients should have DOTA PET. And we also know, and this is within the international guidance that I didn't quite have an awareness of, that contrast MR imaging is the most sensitive test to pick up liver mets. And when you think we can sort of, I think, fall into the trap of these are indolent tumours. And so, why are we going chasing this extrathoracic staging? I could get a typical carcinoid. And we've heard Was say already that we're trying to move away from that thought process. And um, uh, we know that there is a recurrence rate after surgery. In our 10-year cohort, that recurrence was the median time to recurrence was 12 months. That isn't indolent. And the most common site of recurrence is the liver. So it makes, I think it's a real call for us to apply the international guidance in a standardized way across all pathways and for all patients. Some of those international guidance, they do make note to say a small peripheral grade 1 lung net, well differentiated lung net, probably questions the role of DOTA imaging. And that might be the situation where you would go to surgery, maybe just with your MR staging to make sure that that's complete. But otherwise, it's DOTA PET, MR liver with contrast, with tissue first. And I think, as I said, it's really something for us to push forward. And there are conversations happening within national forums about us having an optimal pathway for these tumours. And maybe something like this could be the backbone of it.
And I think there are some challenges, aren't there? Because we often see patients where you think they have a typical neuroendocrine tumour on your initial biopsy, and then they have a resection, and actually it turns out to be a grade 2, or what we used to call an atypical, when we look at things like a Chi67 for looking for proliferation or different features of necrosis. So it is always challenging, particularly for these smaller nodules, to get a decent enough biopsy pre-procedure, isn't it, I guess?
So just to add to what both of you said, really, tissue first means you get that gallium scan in early. And we know from the research that we've done in Manchester, 26% of patients who have a gallium scan alter pathway because of the gallium scan. And not all neuroendocrine tumors need invasive resection. And so it can stop us doing unnecessary things. And so tissue first becomes very important in this situation. And also the FDG PET isn't always the most useful thing that we need. It's actually the gallium scan that we need.
And I think access to DOTA PET is something that I think we'll probably touch on at the very end as well, but it's incredibly difficult, I think, particularly as you move further north in the country to get a DOTA PET. Certainly we don't have access to a DOTA PET locally in Nottingham, and patients would have to travel. So it is not something that currently is widely available, unfortunately.
There's some brilliant, there's a huge meta-analysis that showed the sensitivity for DOTA is 91%. For FDG PET, it was 70% in that meta-analysis. It's a substantial difference of accuracy of staging and planning treatment. And there is real inequality. And listening to that patient voice of standardized care and good patient experience, we've got to address those inequities, and actually maybe having national pathways is the way to do it. We establish what the optimal pathway is, and then we use that as the driver to try and implement that access.
Yeah.
What we mustn't allow is the tail to wag the dog. If there is a need for something and it's useful, then we have to look at why we haven't got the capacity to deliver that modality. And that's where we need to go to with this.
And what's the challenge with the isotope that we need to use in terms of it being more difficult for people to access it compared to FDG PET, for example? Is that something that's easy to fix?
So, you'd really have to ask a nuclear physicist about what the issue is. But I believe that there's a global issue with it because of the wars in accessing the isotope. But there is also, we have a lack of capacity of nuclear physicists to report on these scans. And really, so that is a capacity issue, and that needs to be addressed. But sometimes you address these issues by creating or demonstrating the problem. And if we all continue doing octreoscans, scans, we're not demonstrating the problem. We have to optimize our care, especially for these cancers, which are an orphan tumor that are in many ways neglected in many other ways.
And I guess that's the issue, isn't it? We know that we can't get a dotatate PET, so we don't request it.
Yeah.
So it does become something where we're not demonstrating a case of need, are we? Which is always a challenge. So I would hope that there'll be some changes in pathways, or we can at least try and demonstrate things. But for early stage lung neuroendocrine tumours, we do still have surgery and adjuvant therapy, as we do for most other lung cancers at an early stage.
So, so most of the patients that wind up in the follow-up clinics are resected patients. So 70% of the patients that come through our doors are resectable and patients that have had resection. And 70% of them are T1A, N0, M0, typical neuroendocrine tumours that really need very little follow-up. They have very little chance of relapse. The grade 1 neuroendocrine tumours, the typical NETs, have a lifetime chance of relapse of between 1% and 5%. And the atypical or the grade 2 neuroendocrine tumours have a lifetime chance of anything between 15 and 50% chance of relapse. So that's much higher. And as Matt has said previously, these cancers have a predilection for the liver, 50%, for the other lung in 30%, and then lymph nodes, bone, and skin in 20% each. So they express a malignant potential post-resection, and that's why follow-up becomes very important for these patients. In terms of adjuvant therapy, that's much more controversial. The evidence is lacking. The guidelines don't agree with each other, the national guidelines, the NANETs, the UKNETs, and the NCCRN guidelines don't really agree with each other. And that's because they're basing their data on retrospective adjuvant studies, which are propensity matched. So you don't really get a feel for what you should be doing. So adjuvant therapy really needs to be decided in a high volume centre, used to following up these patients, and on an individual case by case basis. We do know that the two things that predict relapse are lymph node positivity in a patient and the atypical or the grade 2 nature of these cancers. And so that's a good starter, but we've never been able to really design an adjuvant study because of the lack of statistical knowledge we have about these cancers, how to power such a trial, and really how to select the patient and then how to select the adjuvant treatment. So we're lacking in all sorts of things. And so previous adjuvant attempts have failed because of that. So we have a long way to go. But I think as a community, if we all work together, we can probably create good retrospective data on this.
And I guess, again, that moves us on to this surveillance and survivorship, and maybe actually for typical, grade 1 lung neuroendocrine tumours, people have been very reassured, perhaps, and they haven't been offered the duration of follow-up that perhaps we now think they need.
Yeah. And we definitely heard this from at the education day. We had patients there telling their stories about the communication that we touched on before, being told, oh, it's okay, you've got the good cancer, or being told it's benign, and really actually only getting their information when they meet that specialist NET team, and actually then that's the team that's been there to support them then through their journey, living with beyond cancer. And I think it's another spotlight onto the need for knowledge about survivorship. There is variation across the country in who's doing the follow-up, where that follow-up is happening, the length, the duration, and I think it's very clear that these patients need long-term follow-up. both for the risk of recurrence and managing symptoms post-surgery, the psychological impact of a cancer diagnosis, and coming to terms with that. And it feels like another call to arms for us to standardise processes and be sure it doesn't matter where you're diagnosed with a well-differentiated lung net across the country, you can expect a certain level of knowledge in the clinicians that you meet across that pathway, a standardised diagnostic pathway, set forms of evidence-based treatments, and then specialist follow-up and care afterwards.
And how should we follow someone up in terms of imaging, or what should we be doing in these patients?
So there are very good guidelines now written by UKNets, which now reference that very carefully for both the grade 1 and the grade 2 nets. And so it is a long-term follow-up. The issue with these cancers is we don't truly know what their survival curves look like. We don't really know when those survival curves flatten. And so as a consequence, we know that relapse is most likely going to happen late rather than early. And so that's why we advocate a 15-year follow-up. Without going through it in great detail, because you can access this on the UKNet website, generally the follow-up is approximately once every year to every 2 years, with CT scans, contrast-enhanced CT scans in the first 5 to 8 years, and then follow up with scans if needed beyond that. But I would reference the UKNet guidelines for more details on that.
And I guess we're moving on then to the proportion of patients who actually need systemic treatment. And again, it seems like the evidence base is there for some treatments, but not there for other treatments. And I wonder if you could just briefly talk us through what you do for grade 1 and grade 2 in that systemic setting.
Yeah, so this it's not straightforward, and that's why it needs to be done within a specialist centre. But essentially, the first place to start is to realise that there is only one licensed commissioned treatment for pulmonary neuroendocrine tumours, and that is everolimus. Not even the somatostatin analogues have gained commissioning for these cancers, but we borrow the evidence of the GI nets, and so it is superimposed onto these. So essentially, a rough way of thinking about this is that if the cancer presents without syndrome, so assuming that this is without syndrome, if it is a grade 1 net and it hasn't metastasized to too many places, and the person is well, and there isn't bulky disease, it is reasonable to start on a somatostatin analog. If the patient is anything but that, so has more disease, or has a grade 2 net, so an atypical net, or is symptomatic, they need to really start on chemotherapy until they are stabilized, and then you can put them on somatostatin analog beyond that. At second line, we have the best evidence, which is the RADIANT-4 trial bringing in everolimus, and that is commissioned by NICE to use everolimus. There is a drug called cabozantinib, which is currently being evaluated by NICE. The decision is awaited as to whether that will become a treatment beyond the use of everolimus or chemotherapy, but that's not clear yet. Immunotherapy has never really worked for this cancer, certainly not as a single agent. So immune checkpoint inhibitors work for cancers which have what we call neoantigen spill. So they produce lots of neoantigen, and that gets the immune system all excited. And so therefore, the end part of the immune arc is to block the PD-L1 receptor so that the immune system can carry its entire pathway through. There's no point blocking that PD-L1 pathway if the immune system has never woken up. And these cancers essentially are very good at immune escape because they don't create much neoantigen spill, and that's because they don't have much mutations in their genomic makeup. And so that's never really worked. So first-line somatostatin analogues, At relapse, you can use temozolomide and capecitabine as a chemotherapy. Everolimus, third line, cabozantinib, either at third line or fourth line, are generally the ways that you can go through the treatments, and you can re-challenge people. And the other thing to just briefly mention is that these patients can survive a long, long time. Therefore, running out of options is a real risk. And so there's a real skill in knowing when to use. Not all relapses require you to just go in with more treatment. So when to use the treatment and when to use that treatment again. And of course, bringing in trials is very important, and using them as another step on the ladder of treatment is very important to save other treatments for later on.
And I guess that's the key of involving these specialist centres, is that you actually give patients access not only to that expertise, but also to trials that are available, aren't they? Rather than just stopping treatment or like you suggest, treating at the wrong point where you then might run the risk of running out of treatments when you actually do need them.
Absolutely.
And there's another treatment that we were going to touch on, which is peptide receptor radionucleotide therapy, which is something that is not available for lung neuroendocrine tumours, but does have a good evidence base, I think, in the GI setting.
So it has evidence base in both. It's stronger in the GI setting. The registrational trial that brought PRRT into NICE approval was called NETTER-2, and that excluded the lung nets. And that therein lies the problem. The evidence wasn't there for the lung nets. Since then and before then, there have been trials that have shown some efficacy with the lung nets. And where we have used compassionate PRRT therapies, we found it very useful with the lung nets, but currently it isn't commissioned in the UK for usage in the pulmonary or the bronchial nets, which is very unfortunate. But evidence is coming. There are trials that are currently being done, which will hopefully provide that evidence.
And can we just touch, for people that haven't heard of it, what actually is peptide receptor radionucleotide therapy?
So basically, the neuroendocrine tumors generally have 5 somatostatin analogs on their surface, receptors on their surface. And somatostatin receptor 2 is the one that we particularly target for when we use octreotide or lanreotide. And PRRT is essentially an agent which binds to the somatostatin receptor 2, and it has attached to it a mode of giving radioactive doses to that cell. So it's a very targeted way of giving radiation doses. And those radiation doses tend to be either beta radiation, beta-2 radiation, or gamma radiation.
Well, the DOTA PET imaging is critical for PRRT. It's another reason why we need access to it. Is it the case if the tumor is avid on a dotatate, then PRRT should work better? Does it work like that?
So more or less. So actually, it's if PRRT, if the somatostatin analog receptor is not found on a gallium DOTA scan, then that patient is excluded from PRRT. So it's really important. So DOTA scans, you have to remember, are not just diagnostic; they're treatment informing as well. And they're treatment informers in this way. They also they're treatment informing in terms of somatostatin analog use as well.
Yeah.
And it sounds like, I mean, I'd not really heard of PRRT, to be honest, but it sounds like one of the problems we have for the lung is that the ligand that the lung tumours often suppress, we don't have a license, the SSTR4 that lung nets express, we don't have a licensed ligand to target that at the moment. Is that one of the issues we face in the lung?
Yeah. At the moment, yes. But in the future, I think that will change.
And I guess if we're going to finish, we've mentioned, as we've gone through, a lot of unmet needs and key priorities, I think. So I think it would be good to try and sort of bring some of those together. So I don't know, Matt, if you want to sort of start with things that you think are key priorities and things that we're missing from a lung neuroendocrine perspective.
Yeah. I guess I go back to what I said at the beginning. It's brilliant that BTOG are doing a podcast on this topic. The more spotlight I think we can shine on this topic, the better. The more we educate, the more all clinicians understand about neuroendocrine tumours, the better. Because the messages really from our patients are loud and clear. There can be inequity of access to specialist care, be that the right diagnostics, be it the right specialist teams for our treatment or survivorship. And they really did say some incredibly powerful things at that at the education day. That they talked a little bit about the dangers of having a rare tumor, and Waz, I think you talked about it as well. That word "rare" is almost a little dangerous in that um, it can make you accept that we don't have the equitable services for everybody. It can make you accept that there isn't an urgency around the research and developing new systemic therapies because it's a rare tumor. But we also heard on that day that it really isn't becoming that rare anymore, and we are diagnosing more and more NETs, and we're diagnosing more and more lung NETs. And the patients said on that day that we're their hope, and hope is only meaningful if there's action, and such powerful things. So I think this slide summarizes it really well. We've got it's about equity of access to specialist MDTs, to specialist services, to specialist clinicians, standardizing our diagnostic pathway. I think that's a real it's meaningful and it's achievable, and we can do that, and we can standardize how we work. I think there's a real urgency to drive research in this field and look at the commissioning for PRRT. And maybe it's not about waiting for the evidence that's coming, but driving the conversation now to make sure patients who require access to it can access it.
Yeah. So, from my point of view, a national database is important because we need to collect data from the entire nation so that we can develop the survival curves and develop the natural history of this cancer quickly. We need to standardize the diagnostic pathway. We need to standardize the management sequencing so that once again, when we're looking at retrospective evidence base, we've got a standardized way of doing it. We need to centralize care. For these cancers, it needs to be a high volume center that's seeing these patients to gain that experience and employ the right people. It needs more trials for more options. It's a bit of an orphan tumor, this, for a patient that has, let's say, a prognosis of 20 to 25 years, when you've only got 4 options and only one of them is licensed, that's not much comfort to that person. So we need more options more quickly. And of course, the biggest unmet need is building trust in these patients. Matt touched on this thing, rare cancers. Rare cancers give all sorts of excuses for having a lack of knowledge, essentially. And I think prevalence is the thing that defines rarity, not incidence. And the prevalence of these cancers is much higher than its incidence. And actually, if you really look at prevalence in 2026, it's probably not a rare cancer anymore. And so really we need to kind of work together to develop the knowledge we need to inform our patients.
Thank you, both of you. I think it's been really enlightening, and I've certainly learned a massive amount that I really didn't know before, including really that we shouldn't even be calling these carcinoids anymore, which I think we're still definitely do. So I think it's been incredibly helpful, and as Matt said, it's great to have a spotlight on lung neuroendocrine tumours and to recognise that they do need to be managed differently to our pathways at the moment, which very much are set up for the non-small cell lung cancer patients. So thank you both of you for taking the time to go through things this evening. And for those people who've listened, this is obviously available on all platforms, but if you want to see the slides that have gone alongside this, then if you go onto the BTOG website at www.btog.org. Then it is available if you log into the education section. You can register and it is free to be a member of BTOG. It will also be available on platforms that do allow video sharing, such as Spotify, and possibly also on the BTOG YouTube channel if you have a look shortly. So thank you very much.
Thank you.
Emma.